here and his slides are ready. Guess we'll be ready for Dr. Schwartzberg. As he comes up here, I want to remind all of you that are signing up for CME credits that to make sure you stop by the front desk where Carlene is and pick up your certificates before you leave. So anyone who may be leaving the conference early. Okay.
Try it. Actually, I'm Dr. Charles Weber, and my partner, Dr. Schwartzberg, is unable to be here today. Now, okay, I'll try with this then. Could I have the first slide, please? Is it up there? Could somebody assist with the slides, please? Oh, they're on? Oh, okay. There's not a tray on the projector. Okay. As most of you, I'm sure, are aware, Lyme disease was first described in this country and first discovered in this country based on the rheumatologic manifestations. Juvenile rheumatoid arthritis, or what was thought to be juvenile rheumatoid arthritis, was discovered in the towns of Lyme, East Lyme, and East Haddam in Connecticut at a frequency of over 100 times chance alone. This prompted the investigation by Dr. Steer. 25% had this unusual, at that time unusual rash called the EM rash. And unlike other forms of oligoarthritis or monoarticular arthritis, oligoarthritis, by the way, means 4 or less joints, monoarticular meaning 1 joint. And unlike other forms of oligo or monoarticular arthritis, 71% had recurrent attacks, but in between attacks they were well. Of the initial 55 patients that Dr. Steer and his group saw who were not treated with antibiotics, 20% had developed an EM rash, and that was it. Other than that, they had no other problems. 20% developed EM rash with arthralgias. 50% developed the EM rash with intermittent episodes of arthritis, and 10% developed chronic arthritis. You notice they all had EM rash because that was the way the disease was defined at the time. Of the patients who developed the chronic arthritis, 3 out of 6 spontaneously resolved within 18 months. 2 out of the 6 developed permanent joint damage. And the joint fluid is usually an inflammatory type if you take it out and analyze it. In addition, the people who develop the chronic arthritis usually have a genetic marker DR4 or what's not listed up here is DR2. Of the 55 patients, 5 developed symmetric polyarthritis resembling rheumatoid arthritis. This isn't often spoken about, but it does occur, and it may be that Lyme is one of the triggers for rheumatoid. Okay, in stage 1 or early, the rheumatologic manifestations are generally the myalgias and arthralgias, stiff neck. You don't often see frank arthritis, but there can be achiness in many different joints. In the early disseminated or stage 2, you can develop migratory arthralgias or even migratory arthritis. And in stage 3 or late disease, you can also develop either intermittent or chronic oligoarthritis. And what's missing from the slide is that you can also have the polyarthritis. In addition, typical patterns of joint involvement are listed here. In early, the migratory arthritis occurs in about 20%. Mid-course, about 60% of the people with arthritis will develop an intermittent oligoarthritis, and late, about 10% can have chronic oligoarthritis. Now, with the arthritis, the attacks generally are self-limited, although they can become chronic. but usually they last from several days up to 11 months with a mean of about 3 months. The various joints that are affected are listed here. The knee is the most commonly affected of all the joints. It's generally a large joint arthritis. The hip can be affected in about 9%, the shoulder in about 9%, ankle in about 7%, and the elbow in about 2%. You can also develop arthritis of small joints such as the MCP joints or PIP joints of the fingers. Now, in morbidity and mortality report in January of '88, they talked about the people who had Lyme arthritis in Connecticut during that time period. And about 83% had EM rash, and about 24% developed arthritis. Arthritis may not be, actual frank arthritis may not be one of the more common manifestations of Lyme. Chronic monoarthritis can occur from many things other than just Lyme disease. This is just a few of the different diseases in which you can find it. Intermittent arthritis can occur from various diseases as well. You notice Lyme disease is here, but there are many other diseases that can cause it as well. And acute polyarthritis can also occur in many different illnesses. Okay. There are many different rheumatic manifestations of Lyme disease besides just arthritis, and several are listed here. There are certain types of arthritis that Lyme can mimic: rheumatoid, juvenile rheumatoid, of which there are 3 types. You can have monoarticular arthritis and juvenile rheumatoid arthritis. You can have oligo or quasi-articular, and as I mentioned before, in that disease you'd have about 4 or less joints that are affected. And you could also develop polyarthritis. There's another type called Still's disease that really would not be mimicked by Lyme disease. Reiter's syndrome, there's a report on that. Septic arthritis. At times, Lyme arthritis can actually give you a hot, red, swollen joint. It's not always like that. More often, it's warm or cool. It's not red, and it doesn't really appear inflamed like septic arthritis. But it can resemble that. It could also resemble gout for the same reasons, and it can resemble osteoarthritis. If you have somebody who is 50 or 60 and they have a knee that's a little swollen and it's painful, it's not red, it's not hot, the first impression might be that they just have osteoarthritis, especially if there are no other manifestations of their illness. And then there's also soft tissue rheumatism, fibromyalgia-like syndromes, polymyalgia, stiff neck, headache, and tendinitis. It's not really well appreciated, but once again, Lyme can present as a symmetric polyarthritis. In this study, there were 84 patients who presented with seronegative rheumatoid arthritis. In other words, they did not have rheumatoid factor. In that group, 62% negative Lyme titers, 62 patients, and 22 patients had positive Lyme titers. Of the ones with the positive Lyme titers, they responded to antibiotics, and they tended to be younger in general. This is a patient who has rheumatoid arthritis, and she was well controlled with her regular medications for rheumatoid arthritis until she was bitten by a tick and developed an EM rash. At that point, her rheumatoid arthritis flared, and you can see the swollen MCP joints and PIP joints, as well as the wrist being swollen. Once she was treated with intravenous antibiotics for about 2 weeks, the rheumatoid arthritis once again quieted down and continued to be able to respond to the regular rheumatoid medications. This goes into another disease. This is a patient who has Sjogren's syndrome. The interesting thing here is that his Sjogren's syndrome was very, very mild. It consisted only of a mild dry mouth and dry eyes until he was bitten by a tick and developed an EM rash. Following that, the Sjogren's syndrome became very active, and he developed a multiple sclerosis-like syndrome, which probably was on the basis of the Sjogren's syndrome rather than in a direct infection from the Lyme disease. He developed very large plaques on the MRI scan. Treatment with IV antibiotics helped to quiet down. Systemic symptoms like fatigue and generalized arthralgias and myalgias, but it did not eliminate the MS-like syndrome. What we think happened with this patient is that he had the underlying Sjogren's syndrome. It became exacerbated when he developed the Lyme disease, and following that, he didn't really quiet down that much. It just brought out his autoimmune disease much worse than it had been before. There's really nothing much to see on this slide other than to remind me that one of the joints that is often affected and was not mentioned in the previous slides is the temporomandibular joint. This patient had a great deal of pain when he chewed, and palpation of the temporomandibular joint was quite tender. This is just an example of the most common type of arthritis that we see in Lyme disease. You can see the swelling in this knee relative to this one. It's very difficult to see this picture, but this was a young man who developed what really appeared to be a septic joint. His hip was very, very painful. He could not move it, and he could not actually even walk as a result of his Lyme disease. Once he was treated with IV antibiotics, he responded very quickly. Within a week, he was able to walk, and within 2 weeks, he was much better. This is another type of arthritis. This was a minor articular arthritis just in the elbow. But the interesting thing about this patient is that he actually developed erosions in the joint itself. So he developed an erosive synovitis secondary to his Lyme disease. Reiter's syndrome is a syndrome consisting of seronegative asymmetric arthritis following urethritis or cervicitis and infectious diarrhea, one of those. This is a syndrome which has been shown to be associated with Lyme disease. It is often associated with inflammatory eye disease, such as conjunctivitis and occasionally iritis, balanitis, oral ulcerations or keratoderma. Keratoderma is a type of skin rash, but generally we don't see that type of skin rash if the Reiter's is due to Lyme disease. Enthesopathy means inflammation of the enthesis. The enthesis is where a tendon attaches to a bone. That can become inflamed frequently in the condition called Reiter's disease. And we do see that a lot in Lyme disease as well. And sacroiliitis or inflammation of the sacroiliac joints. This is an example, a rather extreme example of the conjunctivitis that occurs in Reiter's syndrome. And this is a good example of the type of arthritis that we see peripherally in Reiter's syndrome. You can see the large swollen PIP joint, but it's not simply swelling of this joint alone. You can see the entire finger is swollen, even in the soft tissues. That's called a sausage digit. And this gives an example of someone with Reiter's syndrome. You can see the swelling of the Achilles tendon. Where the Achilles tendon attaches to the bone, that's an enthesis. So this is an enthesopathy as well as a tendinitis. This patient had Lyme disease, and he had Reiter's syndrome as a result of his Lyme disease. He did not have any problems until he was bitten by a tick and developed the EM rash. At that point, he developed pain in the sacroiliac joints, and he also developed a plantar fasciitis, which is inflammation of the bottom part of the foot. Also, where the plantar fascia attaches to the heel, he had a lot of pain there too. That often produces a heel spur if it progresses for a while. There are a few thoughts about how this can occur. Reiter's syndrome is thought to be a reactive arthritis, and there's a lot of questions about the possibility of molecular mimicry occurring, in which you have some sort of an infectious agent. Traditionally, we thought of things like chlamydia or Uroplasma urolytica, and that there were antigens on the surface of those organisms which would cross-react with also with similar antigens within joints, maybe in sacroiliac joints, and around the tendons. Basically, what would happen is you would be exposed to an infection, you would then make antibodies against that infection, and those antibodies would unfortunately react with your joints. That is the older theory. There was a newer theory that I first heard from Frank Arnett, Dr. Arnett. This has not been verified, but it is a possibility that maybe what we're really seeing is a hole in the immune system, a selective hole. When we're first born, we have a thymus gland, and the thymus gland takes all those white blood cells out of your body that would react with your own antigens, with your own tissue antigens. So it leaves those absent, otherwise your immune system would destroy you. What may be happening with things like Lyme syndrome is that those white blood cells that are needed to attack the antigens on specific infections are absent, and as a result you tend to develop a more chronic infection with these diseases, such as Lyme disease or chlamydia. He was recommending that we give at least 3 months of treatment with tetracycline for people who have Lyme syndrome secondary to chlamydial infections. So that's another possibility as to the theory behind that. In addition, there are some other rheumatic manifestations of Lyme. There are several scleroderma-like syndromes. Scleroderma is a condition in which the skin tends to become very thick. If it happens in the hands, it become claw-like, and this is a picture of somebody who has scleroderma in the hands. Now, I've never seen anything like this happen in Lyme disease, but there is a similar condition called scleroderma, which is right here. And that condition I have seen in Lyme disease. In this one, you tend to get thickening in the skin, not so much in the hands, but in the legs and in the trunk. This has been reported to occur in the literature in things like diabetes and ovarian carcinoma. It has not been reported to occur in people with Lyme disease. However, I've had 3 patients with Lyme who developed that, and this is one of them. You can see pushing against the skin, trying to curl it up, is not possible. The skin is much too thick, and it just doesn't move. This resolved with antibiotic treatment. Another condition is called polymyalgia rheumatica. This can also be mimicked by Lyme disease. This is a condition which generally occurs in people who are over the age of 50, usually Caucasian. There's muscle pain lasting for at least 1 month, and the most important thing about the muscle pain is that it's proximal. It's mostly in the upper arms, upper legs, can be in the pelvic girdle, and it can be in the shoulders, the trapezius muscles, and in the neck. And it's usually severe morning stiffness and what would be called jawing. In other words, when you don't move around for a while and then you try to move, everything becomes very stiff. And then as you get up and start to walk, things ease up a little bit. In addition, there's usually no muscle atrophy or true weakness. They often are unable to raise their arms above their head, not because of weakness, but because of pain. The sedimentation rates are usually high, greater than 40. Many patients can be greater than 100. And you usually get rapid relief with small doses of glucocorticoids. For instance, 10 milligrams of prednisone will often give relief by the next morning. We usually start dosing them at about 30 milligrams of prednisone and then taper it from there. And this just goes over basically the same thing with the proximal muscle pain here and here. Now, this is a lady, she was really too young to have polymyalgia rheumatica, but she also had a tick bite. I don't believe she had an Lyme rash, but she did have positive Lyme titers, and she was unable to raise her arms above her head. And when I examined her, she had a lot of tenderness proximally in both arms and tenderness in both legs. And she clearly was too young to have polymyalgia rheumatica, but her presentation was the same, and this resolved very well with antibiotic therapy. Within about a week, she was feeling much better. And this is another lady who was clearly too young, who had the same type of presentation. But we did have two people who were in their 70s, both of whom had EM rashes, one of whom had a tick at the center of the EM rash, and they both had the proximal muscle pain and tenderness. The only thing that with the one of them, it didn't seem like it was polymyalgia rheumatica, because although she had some improvement in steroids, it was minimal. And with both of them, their sedimentation rates were actually in the 20s rather than in the 40s, which made us think that it wasn't PMR. In addition, on further questioning, they did mention that they had the EM rashes, and they both responded very well to antibiotic therapy. Polymyalgia rheumatica does not respond to antibiotics. There is a related condition to polymyalgia rheumatica known as temporal arteritis or giant cell arteritis. In this particular condition, you can develop blindness and other things because this is a type of inflammation of blood vessels. If they become inflamed enough, they can close off and then you don't get blood flow to those areas. This was a report in the Journal of Neuro-Ophthalmology in which there was a 71-year-old man with sudden vision loss associated with headache, and biopsy revealed typical giant cell arteritis. He was given steroids, but this did not restore his sight. Blood cultures had been obtained and were found to be positive for Borrelia, not specifically Borrelia burgdorferi, however, and a silver stain of the biopsy material, which was done after getting the blood culture reports back, did reveal a spirochete within the biopsy. He was then treated with IV ceftriaxone, and he did get some partial improvement with his vision, which did not occur with the steroids. So we don't usually think of Lyme disease and giant cell arteritis, but apparently that may be one of the potential triggers of it, and there are several reports of vasculitis being induced by Borrelia burgdorferi. And this just goes into the temporal arteritis a little bit more clearly. Once again, it's about 50 years, just like polymyalgia rheumatica. Generally start off with a headache. The temporal arteries are abnormal. They're tender, or they have decreased pulses. There's an elevated erythrocyte sedimentation rate, usually higher than polymyalgia rheumatica. It's usually greater than 50. More often, it's 90 or 100. There's an abnormal artery biopsy. You get mononuclear cell infiltrates, granulomatous infiltration, and usually you get the multinucleated giant cells. Now, the relationship between polymyalgia rheumatica and temporal arteritis is that about 15% of people with PMR, polymyalgia rheumatica, will have temporal arteritis, and about 50% of people with temporal arteritis will have the polymyalgia. So often people with temporal arteritis will present with the proximal pains. And then there's a whole list of other ones. If these arteries become inflamed, you can get a variety of symptoms. This can cause the headache. You can also get facial pain. You can get claudication of the tongue or jaw. Or you could have a headache due to blockage of the occipital artery. Those are all surface arteries. The more serious complications is that you can develop blindness as a result of occlusion of the ophthalmic artery. And this shows a patient who has giant cell arteritis, and you can see the enlarged temporal artery. Now there are a variety of non-articular manifestations. You can develop tendinitis, bursitis. You can have nerve entrapment syndromes such as carpal tunnel syndrome. Reflex sympathetic dystrophy can occur, where usually it occur in a hand, or it can occur in a foot, where the hand tends to have an erratic blood supply, and it often will become quite swollen. You can see evidence of joint inflammation. It becomes osteoporotic in a patchy way on X-ray. And as time goes on, it becomes kind of claw-like and can develop atrophy. That can occur. In addition, myofascial pain can occur. which is where you have one area which is very tender and you have a trigger point there. For instance, some people get a pain around the scapula, and if you press on that spot, it'll send pain all the way down the arm, even though there's nothing wrong with the arm itself. And then there's fibromyalgia. This, by the way, this list is not specific for Lyme disease. This is just a list of non-articular rheumatism. This is an example of a patient who was bitten by a tick and had an ear rash and developed tendonitis in his shoulder. And as you can see, he was unable to hold the shoulder up. What happened was he was a student at Valley Forge, which is a military school. And because he developed tendonitis and then had to do extensive exercise, he ruptured the tendon. But the whole cause of the problem was his Lyme disease. Now, it's interesting that a large number of people have musculoskeletal pain even following antibiotic therapy. This is from some of the older work in which patients received just oral penicillin, erythromycin, or tetracycline. And after about a 10-day treatment, which at that time was considered sufficient, we still had 50% of them having musculoskeletal pain at the end of the therapy, 44% at the end of the therapy with erythromycin, and 38% at the end of the therapy with tetracycline. Now, there's a lot of talk about fibromyalgia. Basically, I think if you look at this definition, which is the American College of Rheumatology's definition of fibromyalgia, you'll probably agree that most people with Lyme disease have fibromyalgia. It consists of widespread pain for more than 3 months on both sides of the body, above and below the waist, and axial skeletal, cervical spine, anterior chest, thoracic pain, or low back pain, and tenderness to palpation in 11 of 18 bilateral sites. These are the sites. If you check those sites on most people with Lyme, most people will be tender in those sites, and they will fit the criteria for fibromyalgia. That does not mean that they do not have Lyme disease. Fibromyalgia as a primary condition is really a diagnosis of exclusion, not the other way around. You can't say that somebody has fibromyalgia and therefore they do not have other illnesses. There is some thought that fibromyalgia may be due to a sleep disturbance. If you don't get the stage 4 non-REM deep sleep at night, that you will be achy all over and will fulfill the criteria for fibromyalgia. If that indeed is true, then anything that would disturb your sleep sufficiently would bring out this syndrome, and Lyme disease certainly is capable of disturbing sleep. Okay.
Thank you very much, Dr. Schwartzberg. I find it very interesting that we are beginning to have presentations of Lyme superimposed on other conditions, particularly in this case rheumatologic conditions, and of course we've known that it can simulate other rheumatologic conditions. We have a special interest in this, and I've looked at several situations that have come recently, and I thought I'd just mention them because Lyme being as common as it is, we can certainly expect it to be superimposed on whatever other illness the people of New Jersey particularly are unlucky enough to get in their lifetime. And for example, we have now had the following kinds of cases come to us, which we will try to publish soon. We've identified the third publishable case of concurrent ehrlichiosis and Lyme. We had a woman come in with severe hypothyroidism who was a farmer in Salem County who has Lyme. Patients simulating polymyalgia rheumatica who turned out to have Lyme. These kinds of things also we have to keep in our mind because, again, I'll state, Lyme being as common as it is, whatever other illness an individual may be unlucky enough to get in their lifetime in this state until we have better measures of control, they may have Lyme superimposed on, and we can't lose sight of that fact. The next speaker again is Dr. Joseph Berescano, and he's going to talk about rehabilitative measures as an adjunct to the treatment of Lyme disease.
afternoon. I have good news and I have bad news. The bad news is you have to listen to me speak one more time. The good news is that it's a short presentation. We'll not run the whole 40 minutes. Okay, I wanted to talk about rehabilitation therapy in Lyme disease. Now, most of you who know me know that I've been saying for years that Lyme is a difficult infection to treat, and I'm a very large and well-known proponent of aggressive, prolonged antibiotic therapy. I'm here to tell you today that there's more to treating Lyme disease than just antibiotics. We've seen this slide before. The point of it is that Lyme is a multi-system illness. You have a blood-borne bacterium that gets to all the different tissues of the body, causing inflammation, vascular compromise, neurologic problems, and so forth, along with that chronic fatigue, inactivity on the part of the patient. And basically, it's probably inappropriate to think that a widespread disease like this can be completely fixed with an antibiotic, and that's the end of it. As I say, it's more than just an infection. Okay, now what is the clinical need for Lyme disease rehabilitation? Okay, first of all, the patients, as a lot of you know, have arthralgias and myalgias. There's a great deal of stiffness morning as well as daytime, especially after immobility. Patients are chronically fatigued. They're markedly less physically active, including those who had been prior to their illness, and many of these patients spend a great deal of time in bed, lying on the couch, sitting in chairs, and so forth, which then makes them more stiff and more painful. So it's a vicious cycle. Because of their pains, because of the nocturnal disturbances of the endocrine and neurologic systems occurring in Lyme disease, they end up with very poor sleeping habits. They have somnolence and napping during the day and many frequent awakenings through the night and light sleeping, aiding, of course, as you heard before, to fibromyalgia. There are varying degrees of photophobia. They remain in the house more than usual. Their stamina is decreased. And even those who had been athletic prior to their illness often are no longer able to remain physically active. As a result, these poor patients are caught in this downward spiral of more and more disability. From a medical or biological point of view, there are correlates to all this that we see clinically. In my practice, approximately 80% of patients with chronic persisting Lyme disease have a gain in weight, and a similar percentage also have a rise in their cholesterol levels. They demonstrate an objective loss of muscle mass, a higher percent body fat content, loss of range of motion of the extremities, and they develop neuropathies, not just peripheral neuropathies, but as well as autonomic neuropathies. Orthostatic hypotension is very common in Lyme disease, as is dysregulation of pulse rate. As a result of these other factors, we see an objective muscular weakness. Now, in developing a rehabilitation program, what are the goals? Well, obviously, goal number one is to relieve pain and stiffness, and then later on to restore the mobility. Once the patient has received some relief from therapy, you can then get into a program that will start to return the patients to their strength, not just of the muscles, but also of the tendons as well. As a side effect of this, the patients will also hope to improve stamina and endurance, reduce the weight that they've gained, and reduce the percentage of body fat content, and therefore the cholesterol, and overall improve the cardiovascular tone. These are great goals for anyone with chronic Lyme disease, and if it works, that's all the more power to them. So what does this involve? The program is a graded program. What that means is you start very gently, very easily, very slowly with the patients. It has to be very much individualized. The therapy starts with a one-on-one session with trained therapists, either physical therapists, exercise physiologists, and so forth, but that depends on the state of the patient's well-being at the time. Usually we start our patients off with classic physical therapy, all the different modalities for pain relief, massage, heat treatments, whirlpool treatments, TAMs and other electrical stimulation devices, ultrasound, deep heat, and so forth and so on. The point of this is a patient who has a lot of musculoskeletal pain cannot hope to get into an exercise program because they hurt too much. Goal number one is to relieve the pain, get them more comfortable, allow them to start to sleep better and have more energy during the day. You then move into a program to increase mobility, first with passive and then active range of motion. And this could be something done by physical therapists, could be something done by the patient, for example, in a yoga class if they're not that totally ill. But the point is it has to be trained to the patient and done properly. If the patient is not properly trained and they overdo it, they can end up with more injury than they started out with, and even in extreme cases, tendon rupture. This then evolves into a whole body program of conditioning. This is something that is not often done by physical therapists. And one of the things I'll show you a little bit later on is the protocol that we use. But if you send patients to physical therapy, the patients will say, well, they put me on the exercise bike for half an hour or 20 minutes, whatever. Then they had me do some leg lifts and I went home. I said, what about the rest of your body? The point is it has to be a whole body program. Every single muscle group has to be involved in the program. Starting off, for example, with an exercise physiologist, once a patient is well enough to get out of plain routine physical therapy, you can enroll them in a gym, for example, where they might have classes on yoga, on stretching and toning, eventually even body sculpture, which is a whole body program of mobility and strengthening. Again, the emphasis is on whole body program. The patients will be doing exercises that are thought to be very light calisthenics, for example, lifting 1 and 2 pound weights, doing some leg lifts and so forth. And the goal here is not to strengthen the body into like Arnold Schwarzenegger, but it's to have many, many, many repetitions with a small weight. This helps to increase the strength of the tendons first, with the muscle strength coming later. Every muscle group is worked individually. In other words, one muscle group is worked on at a time, then stretched, then the next muscle group is worked on. The stretching is a very, very important part of this because it helps to not just restore mobility and relieve pain, but also allows the patient to do more without suffering an injury post-exercise. This basic outline, this body sculpturing program, forms the core program of rehabilitation. Let me show you a few more slides. This is to emphasize, number one, the one-on-one nature of the therapy program. The lady in the black sweatshirt is a trained exercise physiologist. She has a master's degree in this program, and she's working one-on-one with a Lyme patient. And not only is it careful one-on-one, but you also notice that she's helping her some stretches. I call this the pretzel class. Sometimes the patients can stretch on their own. Other times you actually have to have them assisted in this way. Another example of it. I don't know why she's smiling, but we're getting this lady to stretch her back, her shoulders, her neck, and it's being assisted by the therapist who's very carefully, hands-on, one-on-one, getting her through the program. Doesn't show too well, but the next phase involves what I had mentioned before, a whole-body calisthenic program using very small weights with a lot of repetitions, using every different muscle of the body in turn. Here we see the upper extremities. We see the same patient before. Now this is an interesting exercise because she's lifting the weights with her arms and with her elbows against the supporting beam. What this does is it isolates those specific muscles so they are specifically being used. The lower part of her body is supporting her in a way that's an isometric exercise. So here she's involved in active range of motion, strengthening and stretching her upper extremity, simultaneously working on a strengthening isometric exercise for the lower extremities. Again, a trained therapist can do that. What I tell my patients over and over is I don't want you to buy a tape and jump around to Jane Fonda. You need a one-on-one with a trained therapist to guide you through this. Again, full stretching, you see she's working now with the shoulder and upper extremities at the same time, isolating the leg muscles and abdominal and back muscles as well. Very often hear that the way to relieve back pain is by abdominal exercises. Not only is that true, but you do have to obviously focus on back muscles as well. Here again we see some abdominal exercises, again one-on-one, and the therapist is actually touching the lady's abdomen, checking the muscle tone, feeling for abnormalities, feeling for when the patient gets fatigued because you don't want to overwork the patient. Again, more one-on-one. What she's doing in this episode is not a straight sit-up, but actually a twisting motion to strengthen the side muscles, not only of the abdomen, but also the back, again to relieve the back pain and hip pain that accompanies Lyme. This is an exercise, I'm going through the body piece by piece, involving strengthening the legs. She's holding the weights on her shoulders and doing some very slow and careful bending exercises with the lower extremities, again, to get the strength back, to increase mobility. This type of an exercise, if it's done with a lot of repetitions and done carefully, can become an aerobic phase with absolutely no impact whatsoever. In some of these classes, we've gotten our patients into an aerobic phase where the legs have never left the ground. There's no impact whatsoever. Okay, so the protocol. Number one, you may want to enroll your patients in for example, a stress test first, or cardiac evaluation, to make sure that they're well enough to go through an exercise program. What I stress is to have the patients go through a whole hour at a time. I'd rather they do a gentle hour focusing on all the different parts of the body rather than do something strenuous for 20 minutes and have to stop. I recommend the patient be seen 3 days a week, in other words, every other day, so there's a day in between to cool down. And as I mentioned before, it's better to do a gentle hour than to stop early because of overwork. But I've often told my patients, and this helps a lot, immediately after exercise, take a hot bath or a hot shower, and then plan to go to bed. In the beginning of this program, once the patient is well enough to get into the exercise phase, they're going to find that after an hour of exercise, even if it's mild, they're going to get very much fatigued. And the point is, go to bed, don't fight this. In the beginning, they may actually sleep a half hour, hour and a half. As the weeks go by, the amount of sleep they need becomes less and less. And usually at the 6-week to 8-week point, they don't need sleep anymore. Beyond that, there's also a crossover. In other words, the exercise energizes them, and they feel better from the exercise. And the hour that they spend 3 days a week makes them so much more productive in the rest of their life that the hour spent is worth several hours in return for the extra efficiency of their life after that. Aerobic programs are also added on, but they're added on later on after many months of the basic core program of body sculpturing and calisthenics. And the aerobics don't take the place of the basic core program and an add-on. As I mentioned, many of the patients go through the program and they feel that they're getting much better, but they say, I feel like doing more. Now that I'm exercising for an hour, I'm really not tired, I'm actually energized. I want to do a bit more. Believe it or not, that does happen. That's the time when they could add some aerobics to the program, but again, it should be low impact or no impact, and very much individualized based on the patient's abilities right then and there. I did do some very informal research on this. What we did is we took 30 patients with chronic persistent Lyme disease who were under treatment with antibiotics, enrolled them in a hospital-based physical therapy program following the protocols that we developed. All the patients in the program did benefit to some degree. After they pretty much reached the end point of as much physical therapy as they could benefit from, in other words, massaging is great, but how much of that's going to bring out or correct Lyme disease? A lot of these patients said, I feel better, but I don't want to stop. I don't want to give up the physical therapy. I want to go beyond this. 16 of the original 30 did go beyond and enjoyed or joined an exercise program where they enjoyed the one-on-one attention, at least initially, that I showed you with the therapist before. In all of these cases, every single patient of the 16 had the remaining symptoms resolved once their therapy ended, and they have remained well. Now, does this mean that exercise cures Lyme disease? You know what? I don't really know. Does it mean that they really were over Lyme disease and this was a last effort to get rid of the remaining fibromyalgia and post-Lyme disease? Well, possibly that's correct. But is there some other effect? Has the aggressive exercise program improved their circulation, affected their immune system, had some direct effect on spirochetal killing? I don't know that. But the point is, this changes the whole idea of rehabilitation. It's no more or no longer simply getting the body back in shape. A careful program like this actually becomes part of the therapy into helping the patients get over Lyme disease. So let me go through the recommendations. I'm happy my slides are not backwards. First of all, you have to have the right choice of therapists. In the beginning, you need to start physical therapy. And if you've ever gone to a physical therapy program, you see, like I said before, 20 minutes on a bicycle, then do some leg lifts in your home. There's no one-on-one. There's no careful whole-body program to it. In the very back of the abstract section of your handout is a protocol that I've written up that's very detailed, and it's in the form of an instruction that you would give to the physical therapist and exercise physiologist to help them know what's going on. Because without these detailed instructions, the patients are not going to get the therapy they need. In the beginning, we start the physical therapist, then the patients eventually graduate, if you want to say, from physical therapy, and the program is either blended into or changed to an exercise type of program. If you have available in your area a sports medicine program, that's the best place because the patients will get the physical therapy and the exercise treatments all under one roof as a continuous improvement and greater program as time goes on. What's necessary is to speak to the therapists personally to outline the plan and the goals. Again, begin basic physical therapy immediately at the time of diagnosis. Don't wait, I'll do therapy 6 months from now. Start day one. The earlier you start, the sooner the patients feel better and the better the outcome. Use the physical therapy for the initial control of the pain and restoration of mobility. Advance as the patient's degree of wellness allows. And be sure that they address not only the specific problem areas, but once again the whole body in a generalized sense. What's important about this one-on-one is, in the beginning, the patients have to be categorized by the therapist what they really need. What I recommend is that patients spend the extra money, hire the therapist, might cost them $50 or $60 for an hour session, and get this careful one-on-one to find out what the patient's needs and abilities are, and so the patient can then be given a few one-on-one sessions to get started, and then mainstreamed into the regular classes and the regular exercise programs that are given at the facility. The
The patients need to be specifically taught on the proper technique of exercise, especially because they're ill, but in general, if they don't do it right, they're going to hurt themselves. They have to be told and instructed and given the proper warm-up. They have to be instructed on the proper breathing techniques, how to protect their joints and tendons during the program, how to cool down properly, and how to stretch during the exercise and afterwards. Again, detailed written instructions to the therapist are very necessary, and feedback and communication between the therapist and the patient and between the therapist and the physician is very important. If the patient goes to therapy, comes home a little achy for a few days or for a few hours or so, maybe to the next day, but then feels better, that's pretty much okay. If the patient is completely wiped out or has soreness of a joint or a tendon lasting for 2 weeks, then obviously they're overdone. So every therapy session should be begun by the therapist with an interview of what's been going on, how do you feel, and how did the therapy affect you. And that is it in a nutshell. I hope I've helped. I'm glad to keep most of you awake before we ended. And before I close, I do want to thank the organizers and everyone else here. I think it's been a great program, and I give you a lot of credit for coming during the week. Thank you.
Okay, what I'd like to do is all the speakers who were here for this afternoon's section, I'd like to have them come up, but first I'd like to have everyone take about a 5 to 8 minute break, get up and move around a little bit. We'll have the speakers back out front here, and we'll follow the same protocol we did yesterday afternoon, though this time I'd like to have everyone who has questions write them down, and we'll only take one question from everyone so we get most of the questions done. But then we'll meet up here in about 5 to 8 minutes. Thank you.